All right, good morning, everyone. Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractic physician at Gates Brain Health. This morning we're talking about pediatric migraines, and we're going to be going through this wonderful slideshow that Melanie put together. So this is an interesting topic. I'm just going to run through a few slides here. But to begin with, I think it's important that we just talk about migraines as a whole. Migraines are one of the most common conditions affecting adults, and it also is a common condition affecting our youth. And there's actually a variety of what they call childhood periodic syndromes that affect our kids. And it's probably even more interesting to find out that something like infantile colic is now being classified as a childhood periodic syndrome within the migraine spectrum. So we're going to go through all of that, and we're going to hopefully answer some of the questions that were posted about this video when we talk to our friends and followers on Facebook. And if you have any questions, just put them in the comment section. I'll try to circle back to them, and hopefully this is applicable. Now, with childhood migraine, certain components of it respond to medications, but it's very interesting, as I'll talk about as we go through this, that a large percentage of childhood migraine patients actually don't respond to medications. And that's all throughout the literature. Just to go through what is a migraine, I think that's important. Let me grab our brain model here. So this is your brain. You need to get appropriate blood flow to all parts of your brain, especially when you're using it. Now, what they've seen is that in migraine patients, there's this tendency for something called calcitonin gene-related peptide, CGRP, to build up in one part of the brain, and it's not flushed out appropriately. So think of like if you're working a muscle and you have a buildup of lactic acid, well, the CGRP will build up as well, and it's not pushed out of the neurological tissue as well as it should by the blood supply. So as a consequence, it builds up. It seems to initiate pain reflexes. It can also be associated with what's called cortical spreading depression, which is seen with the auras that people commonly have before migraine. Not always, but they commonly can have that. And so then the CGRP builds up. We make it an aura, we may not. We develop pain. And then the trigeminal vascular system, or the trigeminal cervical system, basically your trigeminal nerve, starts to sense these pain signals and these pain peptides out here, and then that initiates the headache. Now your trigeminal nerve, which innervates your entire cranium and your face to sense pain, sends most of its signals down into the neck before those signals then cross over, going to the other side to then go up to the brain to realize that somebody's having pain. This is where the neck and the musculature of the head can be important for headache patients. That is because, in recent times we've seen people using things like Botox. Botox can relieve muscle tension. It can relieve, basically it's going to change muscle firing, which can then change input into the neck, which can affect things like migraines. Chiropractors have talked about this for a long time. If you talk to a massage therapist, they're going to have stories where they're working on someone's neck and all of a sudden their migraines went away. And that's the mechanism. Even though the neck is separate per se from an underlying metabolic cause causing a migraine, the neck has great importance. So that's enough about migraines. What about pediatric migraines? So with pediatric migraines, I think it's important that we talk about the childhood periodic syndromes, just kind of running through them. Infantile colic is the first one. Infantile colic is probably going to peak in its incidence around 3 months, but it can go longer. Infantile colic is a great source of frustration for parents, clearly for the child as well. And they've even shown, I think it's like 1% of parents admit to shaking their baby because of infantile colic. If it goes on upwards of 6 months, it's something like 5% of parents admit to shaking their baby or, slapping them or smothering them. This is from the literature. I hate even saying these words. But with that being said, it illustrates that this is a very frustrating issue for parents, clearly, and it's a very dangerous issue for the health, particularly the neurological health of that infant. Now, they thought that colic had to do something with the gastrointestinal tract. They thought that with colicky babies, they had something wrong in their intestines or their stomach. Turns out that they're not finding much wrong in their gastrointestinal tract. And one of the palliative factors or things that really help babies who have infantile colic is to take them into a dark room, into a quiet place. And this is leading researchers, the foremost headache researchers on the planet, actually a lot of them are at UCSF down in San Francisco, to say, well, is this a pediatric migraine issue? And so that is actually where the international headache societies are shifting to and saying that infantile colic is referred to as one of these childhood periodic syndromes within the pediatric migraine phenomenology, as it's termed. So that's good to know. And then after that, we can have benign periodic torticollis. So that's where a young child may develop these issues when they're a few months old, to a year age, where they start tilting their head and their head is stuck. And they can't get their head unstuck for a period of time, then all of a sudden their head goes back to being normal, and they'll have remitting attacks of that. So benign paroxysmal infantile torticollis, that's another one. After that, we can have benign paroxysmal vertigo, which is where a young child all of a sudden is going to complain that they're dizzy or they're unable to walk correctly. Doctors will notice that they have signs of vertigo. Benign paroxysmal vertigo affecting kids is totally different from the benign paroxysmal positional vertigo affecting adults, which really relates to crystals being dislodged from the inner ear going to a part of the inner ear where it shouldn't be. But for kids, the benign paroxysmal vertigo is basically a migraine attack seeming to affect the brainstem, which illustrates an important point. So you can have a migraine, you can have a hemiplegic migraine, where in essence you're paralyzed to one side of your body and you're going to have numbness and things of that nature. That is going to be affecting your motor and your sensory area. The migraine is going to affect that area. Now, if you have a headache and you have a lot of visual symptoms, probably the migrainous process is more affecting your occipital lobe. If you are having a vestibular migraine as an adult, that migrainous process is affecting your brainstem. So kind of the same thing when we talk about these different issues. A child who's having infantile colic, likely the areas of the brain representing the stomach, which would be deep down in the insula, areas such as that might be, the parietal cortex. Those areas are being affected. Same thing with torticollis, it's going to be more the brainstem. And same thing with benign paroxysmal vertigo affecting kids, which then segues into abdominal migraines. Abdominal migraines, you're more going to see this issue affecting school-age children. These are going to be recurring bouts of stomach pain that's typically in the midline. We had a question about this, so it's typically pain in the midline. These are kids who are having stomach pain. They may have, sweating. They may have nausea and vomiting. They may be unable to eat, and the parent takes them to the gastroenterologist because it looks like they have a stomach problem, and the gastroenterologist does a bunch of investigations and is not able to find anything wrong with their stomach or their intestines. So they don't have something like celiac disease. They don't have food allergies that are showing up being demonstrative. And so at that point, lots of times pediatric gastroenterologists will basically conclude that that individual is having an abdominal migraine. And so they've done research about this in pediatric headache clinics and found that abdominal migraines are actually the most common cause of pediatric migraines. So if you take everything I just talked about, and I missed one, which is called cyclical vomiting syndrome, which is typically where people will vomit, the kids will vomit, but it can affect adults, but typically kids will vomit 4 times in an hour, maybe for several hours, but the vomiting doesn't really relieve the symptoms. Whereas if you have a gastrointestinal problem, all of us have had probably the stomach flu at some point. You vomit, at least you feel kind of better for a period of time. With cyclical vomiting, people don't feel better, or kids don't feel better. So going back to the abdominal migraines, that is one area where the medications seem to help, and so there is evidence that nasal sumatriptan, which is Imitrex, most of you would know that, can be of some benefit for abdominal migraine patients. Also, dihydroergotamine seems to be helpful via IV for these patients as well. Now, so that's pediatric migraines, and particularly emphasizing abdominal migraines because abdominal migraines are the most common cause of pediatric migraines. Now, that being said, now let's just talk about garden variety migraine headaches in kids and adolescents. Seems to be pretty common. Estimates are around it can affect around 7 to 9% of children. There was something called the CHAMP trial, and the CHAMP trial was done around 2017, and it was to be published in the New England Journal of Medicine. Now, within medicine, that's one of the top journals. They call it an impact of that journal. So it's a very prestigious journal, and they're doing the study basically comparing a couple drugs compared to placebo. And the drugs were amitriptyline and Topamax. And what they found was that it was something like 51% of amitriptyline patients had some improvement. 55% of Topamax patients had some improvement. Don't quote me, go back and look at the study, but it was something like this. I can get the study to you if you want it. And 66% of the placebo patient population reported improvement. And based on that, they actually stopped the trial. They stopped the CHAMP trial. Because in essence, they were saying, we're seeing no benefit, and if anything, we're seeing more side effects because of the medications than we are seeing benefits. So that was kind of disheartening for a lot of headache researchers because there wasn't a good migraine prophylaxis, there wasn't a good migraine treatment for these kids who have migraines. And from there, they repeated the study, and I think it was in 2020, this was in JAMA Pediatrics. JAMA is Journal of the American Medical Association. And they came out and said, well, Topamax offers some benefit, but not nearly significant enough for us to say that it is beneficial. So in that study, they said it's a little beneficial, it's mildly beneficial, but not significantly. And so that was another kind of important finding for those who are suffering with headaches. So if these medications aren't going to work, well, what can work? And with that, the researchers started saying, well, we also see that kids who have migraines have a lot of emotional strain associated with the migraines. They have a lot of ADHD surrounding the migrainous periods. They may have depression and anxiety surrounding those times. Maybe we need to look at something like cognitive behavioral therapy. So cognitive behavioral therapy, where a psychologist will go in who's trained in CBT, will help that individual to look at the painful event and maybe reframe the pain emotionally. That can be beneficial. Vitamin D, believe it or not, just at a small dose of 2,000 IUs per milliliter, or 2,000 IUs a day, can be actually pretty beneficial in reducing the CGRP, as I talked about, calcitonin G-related peptide. The CGRP levels can go down with taking vitamin D because vitamin D affects calcium metabolism, calcitonin gene-related peptide. So that's interesting. Also, within the adult population of headache sufferers, when I've talked about the underlying causes typically are insulin resistance and thyroid disorders. There's a heavy association between thyroid disorders and migraines. And researchers have known for a long time that if someone who's an adult develops a migraine, they're actually very likely to develop a thyroid condition a few years later. Or they have comorbid insulin resistance. What's insulin resistance? It means you eat carbohydrates and you secrete more insulin than you should. Typically, you're pre-diabetic. You may have gained some weight. Your blood pressure may be up. Your blood may be more viscous. You may have high cholesterol, high triglycerides. So basically, those two factors have been shown to affect pediatric migraines as well. So there was a study in 2012 that came out, basically showed that subclinical hypothyroidism is common with pediatric migraineurs. What is subclinical hypothyroidism? So most of you know what hypothyroidism means. Just your thyroid is not functioning right, it's functioning low. Well, just like everything else, there's a continuum as to what is hypothyroidism and what isn't. And LabCorp may say any number over 4.5 on the thyroid stimulating hormone constitutes hypothyroidism. Now, that's an inverse relationship that confuses people. Thyroid stimulating hormone comes from your brain, and it tells your thyroid to make thyroid hormone. If your thyroid is low, thyroid stimulating hormone is going to go up because your brain's going to send more signals to your thyroid to work and produce thyroid hormone. So if TSH goes up over 4.5, then that can mean that somebody has a thyroid condition. But lots of times their doctor is not going to give them a medication unless their TSH is up around 8. So if someone has normal thyroid hormone and their TSH is around 4.5, they're considered to have subclinical hypothyroidism. And some studies say anything over 2.85 is subclinical hypothyroidism. Some studies say anything over 3.7 is subclinical hypothyroidism. It really depends on who you talk to. But in this one study in 2012, they said a lot of pediatric migraineurs have subclinical hypothyroidism. And if they have subclinical hypothyroidism, why is their thyroid not working? Likely it's because their immune system is attacking the thyroid. Around 70-80% of individuals are going to have that, called Hashimoto's. So that's something important. If you have a nephew, a niece, a child who suffers with pediatric migraines, or if they have, one of the childhood periodic syndromes that I mentioned, ranging from, colic to cyclical vomiting to benign paroxysmal torticollis, benign paroxysmal vertigo, abdominal migraines, you want to look at their thyroid function acutely and have their doctor check their thyroid, but also you want to probably look at the numbers and also have them screen for autoimmune thyroid disease referred to as Hashimoto's. So you say, I want a full thyroid panel and I want them checked for Hashimoto's. That would be my recommendation. I'm not treating those of you out in the YouTube world. I'm just saying those are recommendations or things you can talk to your doctor about. And then insulin resistance is hugely important. They found that if a child has obesity, it's something like their odds ratio of having a pediatric migraine syndrome that won't improve with medication, I think was like 3.5. So looking at a child's body mass, looking at their activity level, looking at their insulin function, their blood sugar function is really, really, really important. So what does that look like? It means you want to get your kid's blood sugar checked. You also want to have their 3-month measure of blood sugar checked called the hemoglobin A1C. You want to know what their triglyceride levels are, because triglyceride levels are an effect of blood sugar. You also want to look at their body mass and their microbiome. We, in essence, have found that insulin resistance, where someone produces too much insulin for a given amount of carbohydrate, is a result of changes in the gut microbiome where the gut bacteria become dysbiotic and pathogenic. So hopefully that summarizes it. Let's just go through a few slides. Here, this article was talking about ketone bodies and migraine prevention. How can a ketogenic diet, so to speak, be effective for migraineurs? Probably the reason is that with migraine headaches, when I talked about the whole CGRP issue, which think of it as like accumulating lactic acid in one part of the brain, there's a lack of flushing of those metabolites out of the brain. Some think that there's impaired local vascular reflexes as well, possibly relating to the fact that the brain cells are not making enough energy, which relates to the mitochondria. The mitochondria are a part of every cell of your body, including brain cells, that makes energy. Your brain is 2% of your body weight. It consumes 20% of the oxygen coming into your body. This is a very metabolically demanding organ in our body. So by going on a ketogenic diet, one is reducing their carbs. May affect something like insulin resistance. And so when they're on that ketogenic diet, they're metabolizing primarily fats and proteins to produce energy, which lots of times can take strain off of the mitochondria. And that's one potential mechanism for helping migraines. Because again, we have to consider with pediatric migraines that the medications commonly do not produce the outcome we're looking for. And just to refresh that CHAMP trial, they were really hoping that those drugs, amitriptyline and Topamax, would reduce the headaches by 50% in a month's time. And they didn't do that. And again, placebo seemed to be more effective than the medications. So this is just a nice diagram illustrating the connection between the microbiome, which are the 37 trillion gut bacteria that we have, our digestive tract, and how inflammation from the microbiome can be a source of inflammation in the brain, and how it can as you can see here, decreased mitochondrial function. It can affect glucose in the brain, things of that nature. So, and as we go into ketosis, we have the possibility to decrease inflammation, help the microbiome, basically change glucose metabolism in the brain, because even if you're not eating carbs from your diet, your body can make glucose through something called gluconeogenesis. This is on the epigenetic diet, and this is looking at folate metabolism. So this is all about how our DNA replicates, and we use folate. This pertains to our MTHFR crowd. MTHFR stands for methyl tetrahydrofolate reductase. It's an enzyme in all of us that should convert inactive folic acid to active, and some people just can't do that. And if you have both copies of this issue for the C677 component of this gene, I know these are a lot of details, it can impair your ability to convert that folic acid down by like 79%. So that's important to consider as well. And this is just illustrating how, B9 from the diet is really important in DNA replication and the formation of what it's called mRNA, and how we then produce our proteins. So this is another nice diagram of migraine headaches, where you see this thing here, it says CSD, that is cortical spreading depression. And cortical spreading depression is very analogous to dropping a rock in a pond. So you drop a rock in a pond and you see those ripples. That same thing, or that shock wave, is happening in the brain of migraineurs. And that depolarization, slow depolarization, is very important then, it seems, in other peptides being released in the dura mater, which is the connective tissue covering of the brain and protective layers. There's other pia and arachnoid matter, but basically your meninges here have these connections to the pain system, which is your trigeminal system. And then this is just illustrating how all the things from our diet can play into migraine headaches. And so we have sugar, and we have processed foods, and not eating right, and then you eat too much chocolate, and you're working out too much, you're not sleeping right, you're around chemicals that bother you, you're under stress, you're smoking, people are smoking around you, on and on and on. These are the factors that seem to push migraineurs over the edge. These are the factors that cause their cup to floweth over, so to speak. Things to be aware of. Okay, and this is illustrating the MTHFR cycle and how we need appropriate levels of conversion of 5-methylene tetrahydrofolate into THF in order for us to recycle this thing down here called homocysteine, which is an inflammatory byproduct. So homocysteine is inflammatory, and homocysteine goes up in a lot of disorders, including things like migraines. It can also be higher in depression, it can be high in schizophrenia, it can be high in bipolar disorder. So homocysteine we want to be normal, and this can be checked for via blood test. This goes up in vascular dementia, the second most common cause of dementia. So we want our homocysteine levels normal, and by having adequate levels of active B9 and B12 is how we then convert homocysteine into methionine. Okay, this is talking about vitamin D as I was discussing, and how vitamin D can affect CGRP. And this was a really, really interesting study. And again, you can see right here, 2,000 IUs per day, which is not a lot. I mean, I have a lot of patients on 5,000, 10,000 IUs a day. So 2,000 IUs a day was significant enough to reduce migraine headaches in these individuals. And I think it was actually CGRP was the main outcome variable. Okay. And I'm just going to run through that. And that's it. So hopefully this makes sense. Kind of in summary, pediatric migraines, around 7 to 9% of kids are going to suffer with a pediatric migraine or childhood episodic syndrome at some point. Again, those childhood episodic syndromes or episodic syndromes of childhood include infantile colic. Infantile colic is now thought to be a migraine, is not seeming to be a gastrointestinal problem. And just keep in mind that foods can trigger migraines. So if taking that infant into a dark room helps them to calm down, helps them to feel better, you may want to think that they're having a migraine. Then we move on into, benign paroxysmal torticollis. Then we can move on to benign paroxysmal vertigo. Any child complaining of episodic issues with their balance and feeling dizzy and being clumsy, you want to start thinking that also from a neurology side and doctor side. Any child manifesting neurological symptoms, you also have to think, is there something ominous? Is there something wrong with their brain? But if it's an episodic course where it comes and goes, then consideration in the differential of benign paroxysmal vertigo is justified. We can have cyclical vomiting syndrome, which are periods where a child will start to vomit 4 times an hour, for an hour or many hours, and then it goes away and the vomiting doesn't really relieve their symptoms. Then we get into abdominal migraines, and abdominal migraines are the most common cause of pediatric migraines, and that segment of migraines, the abdominal migraines, seem to respond to nasal sumatriptan and possibly dihydroergotamine derivatives given via IV. So for those suffering with these horrible, painful stomach episodes and they don't have celiac disease and all these other gastrointestinal causes have been ruled out by the pediatric gastroenterologist, then we want to consider abdominal migraines. Then we have garden variety pediatric migraines, which unfortunately don't seem to respond super well to the current medications out there, such as amitriptyline and Topamax, which are the most commonly studied medications. So we want to start thinking other functional variables, things that are seemingly more simple that you can do to address your child's brain health. And so in doing that, you really want to look at insulin resistance. You want to look at subclinical hypothyroidism. Until you are certain they don't, not just that they don't have a thyroid disorder, you really want to look at the numbers yourselves and say, do they have subclinical hypothyroidism? I highly recommend all of you parents out there to look at that if your child suffers with pediatric migraines. And then looking at vitamin D levels, considering something like a ketogenic diet, are things that may help for pediatric migraines. So I think that's it. We're going to repost this to Facebook. I appreciate all of you watching. I hope this was helpful, and we should be back on Saturday with another video. So have a great day. Have a happy Wednesday, everyone, and we'll go from there. Okay, let me escape here, and we're going to